Hi, I'm Dr. Raymond Zakhari. I'm going to give you a crash course in portal hypertension. So let's start with cirrhosis. If cirrhosis is the architectural collapse of the liver, portal hypertension is the hemodynamic consequence. It's not just a pressure number, it's the physiologic bridge between histology and every bedside complication, and including things like varices, ascites, and the hepatorenal syndrome. So let's start with this increased intrahepatic resistance. How does this happen? This is the first domino to go down. Fibrosis and regenerative nodules distort the hepatic architecture. That narrows the sinusoids and traps blood. On top of that, activated stellate cells and smooth muscle contract around the vessels. This is a dynamic obstruction. So resistance is both structural and functional. That's why the non-selective beta blockers like carvedilol work. See, they relax the vascular tone. Think of the liver as a dam. Inflow continues, but outflow is restricted, and the pressure builds. Think of splenic vasodilation. This is the paradoxical overfilling that's happening. Excessive nitric oxide and vasoactive mediators dilate that splenic circulation. That increases that portal inflow even further. So the body is sensing congestion and mistakenly opens up more tributaries to a blocked river. You see, the result is this hyperdynamic state caused by increased cardiac output and reduced systemic vascular resistance. So there's this relative hypotension that's going on. Patients will often have warm extremities and bounding pulses despite a low effective volume. Well, this hypoperfusion state triggers a neurohormonal cascade, right? Because it's a misguided attempt to rescue. So the kidneys interpret this vasodilation as, oh my God, hypovolemia. We don't have enough. Quick, hit the RAS system, trigger that renin, aldosterone, and sympathetic nervous system so that we can hold on to water and sodium. Well, you do that and then ascites forms. So this sets up this vicious cycle of vasodilation and underfilling triggered by the RAS and sympathetic nervous system, leading to further retention, further congestion. Each compensation is worsening the problem. The body's solution has now become the disease process. There are also downstream consequences, things like varices and ascites and hepatorenal syndrome. So in varices, that's because the pressure forces blood through these collateral veins. With ascites, fluid transudes from the splenic capillaries. In the hepatorenal syndrome, the intense renal vasoconstriction collapses kidney perfusion despite normal anatomy. So portal hypertension is this engine of decompensation that once engaged, every compensatory system turns on itself. You have a few pharmacologic leverage points then. So beta 1 blockade, that is designed to reduce the cardiac output and hopefully reduce that portal inflow. The beta 2 blockade is supposed to trigger the splenic vasoconstriction to reduce the portal return. The alpha 1 blockade, like in carvedilol, this relaxes the intrahepatic tone. So carvedilol acts at the heart, the gut, and the liver. It's like a triple threat. Now, clinically, how this manifests, management must target each node in the loop. So you need to reduce that inflow with the non-selective beta blockers or carvedilol, 3 for 1. Then you need to manage volume with diuretics and paracentesis. You want to prevent rupture of the varices, so endoscopic variceal ligation is your friend there. And then, of course, ideally address that underlying cause if you have time and are able. Otherwise, you're going to run a MELD score and evaluate for transplant. So while fibrosis starts the fire, hemodynamics spread it. Portal hypertension is this circulatory price that the liver is out of architectural options.